I just want to throw an astonishing news here that I've read since 2003. That's the life support in hospitals. Actually, the chance of surviving cardiac arrest in hospitals is about less than 20%. It's really something that's scary. However, when it comes to miscarriages, talking about threatened miscarriage or recurrent miscarriages, still we need to save these lives. Those still in utero, but they have a better chance. It seems to be the chance up to 50%. So even we have one way of doing this, and there is a certain medication to do that. And I'm going to talk about this a little bit later. But first of all, I'll have to allude to the fact that miscarriage is a painful experience, reduction in the quality of life, lowering of well-being, and actually functional disability is well documented among patients who suffered recurrent miscarriages. Now, patients of recurrent miscarriage and their partners have been reported to experience depression, grief, anxiety, anger, and hopelessness. Now, up to 50% of women, and also 43% of male partners who have experienced a miscarriage suffer from psychological symptoms for up to 1 year after the event itself. When it comes to pregnancy loss, in fact, there is about 70% of conceptions are lost prior to live birth. Now, we know that there are about 30% chance of failure of implantation, followed another 30% chance of early pregnancy loss that hasn't been documented clinically, and then there is a 10% documented clinical pregnancy losses. And once a woman has had a positive pregnancy test, there is around 10% of risk of having a miscarriage. So let's start with the threatened miscarriage, the prevalence, defined as an ongoing pregnancy associated with vaginal bleeding with or without abdominal pain, and is the most common gynecological emergency. It's occurring about between 15 to 20% of ongoing pregnancies, with a 25% progressing to spontaneous miscarriage. So we have some figures here from around the world, but I can quote the Saudi Arabian miscarriage prevalence, which is around 17%. Now, miscarriages, as you all know, it can be threatened, inevitable, incomplete, or complete or missed. Then we have the cases of, according to the threatened miscarriage data from the UK, that occurs in about 20% of all clinically recognized miscarriages. Once a woman has had a positive pregnancy test, there is around 12% risk of actually having a miscarriage, which is again from UK. Now, ultrasound is very important. It should be the primary test to assess viability, as no therapy can resuscitate a dead embryo. Now, diagnostic criteria for non-viability of a fetus has been really stated nicely in this publication 2013, and this radiological findings of a crown lump length of equal or more than 7 millimeter and no heartbeat, or a mean sac diameter of equal or more than 25 millimeter and the absence of an embryo, or the absence of an embryo with a heartbeat for more than 2 weeks following a scan that showed a gestational sac with no yolk sac, and also the absence of an embryo with a heartbeat more than 11 days following a scan that showed a gestation age with a yolk sac. Look for any pre-gestational hemorrhages, because even this one can contribute to a miscarriage. Exclude non-viability regardless of the presence or absence of pre-gestational hemorrhage. Now, there are two more risk factors that I usually tend to utilize as a predictive factor of this condition. First of all, the bleeding severity. Now, has been found that patients with vaginal bleeding, light or heavy, were more likely to experience a spontaneous loss before 24 weeks of gestation than bleeding with no bleeding. Now, However, the odd ratio of the loss is 2.5 for those who had light bleeder, while the odd ratio is about 4.5 for those who had heavy bleeding, as reported in this very large, interesting multi-center study. Now, the other factor I look at is the progesterone level. Now, here we have like a cutoff that's been stated by many publications to talk about 35 nanomilimoles per liter of progesterone or serum progesterone. So it seemed to be a prognostic spontaneous miscarriage by 16 weeks in women with threatened miscarriage in early pregnancy. So using this cutoff, individual patients can be quickly stratified as being at low risk or high risk of spontaneous miscarriage. There are myths also that we have as doctors to correct among our patients. So if she tell you, because I took that flight, I had the miscarriage, or because she had that she fell down, she had the miscarriage, or because of having an intercourse, she had this miscarriage, or because she had an exercise. No, all of these factors that has been listed here also on this slide, there are actually none of contributory factor to miscarriages, and we should correct the understanding of these women. Now, in fact, we can look for etiological factors, but unfortunately, as you can see here from the two lists of threatened miscarriage and recurrent miscarriages, there are about 50% of recurrent miscarriage that of unknown cause. So all these listed factors, they just contribute about half of the cases, while there is the other half we don't have a reason to understand. We come to the recurrent miscarriages, estimated to be 1 in 4 pregnancies end up in a miscarriage, and about 1 in 100 women in the UK experience recurrent miscarriages of 2 or 3 or more. More than 6 in 10 of women who have a recurrent miscarriage go on to have a successful pregnancy. So most women with recurrent miscarriage would achieve an ongoing pregnancy if they just persist trying. Now, what to do for recurrent miscarriages? I think the simplest thing is just to start with modifying your lifestyle, because these things, these three things, the weight gain, the utilization of coffee and alcohol has been associated, and the figures is very astonishing. Look at this. The increase in BMI of more than 25%, increases of BMI more than 30, actually increased. The BMI was the second most important risk factor after the age in predicting another miscarriage in a woman who had a recurrent miscarriage. Okay. Now, drinking more than 7 cups of coffee per day increases the risk of miscarriage, according to this publication, with a hazard ratio of 1.48. Again, drinking more than 4 drinks of alcohol per week increases the risk of miscarriage with a hazard ratio of about 2.82. Now, there are things that we have to be careful when you state the number of miscarriages. Well, first of all, the consecutiveness. I published a paper in 1991 where we confirmed that only those who had consecutive miscarriage, they tend to have another miscarriage with a ratio of 20% compared to those who had non-consecutive miscarriages, and the likelihood of having another miscarriage is only 6% in this group. So that's in consecutiveness is important to identify the group who are at risk of recurrent miscarriage. Another thing is the number of miscarriages. Whether it is 2 or 3, actually the likelihood or the outcome is the same. However, if you have, which is about between 20 to 25%, however, you have a 4, then you have maybe a higher chance of another miscarriage, about 40%. But if you continue counting, this publication has really told us nicely that between 2, 3, and 4, yes, you have a high risk of likelihood of another of a live birth of something like between 40 and 48 and 40 to 70. But the live birth rate actually after 5 miscarriages actually has been to be identified as even 51%. So the empirical treatment, whenever etiology is unknown, as I said before, because there are 50% of the cases of unknown etiology, then you start to use any kind of things empirically. But have a bed rest, SCG, take muscle relaxant, take aspirin, take heparin, or give some kind of immunological drugs or immunotherapy, cortisone, etc. But we all these publications has been actually these medications or these attempts has been really looked at carefully in various randomized clinical trials, as well as systematic reviews to show that they are not of value. However, progesterone has been shown to be of effect on the preventing the recurrent miscarriage. Well, let's start with the progesterone, as the word pro for progesterone, which is gestation, is something for pregnancy. So we know from the physiological background that progesterone prepared the endometrium with the cellularization of the endometrium, they decrease the contractility of the muscles, improve the blood flow in the uterus, endometrium, and the myometrium, and also changes in the vaginal epithelium and the cervical mucus. Drop in the progesterone has been shown to be related with the blood loss, with fetal loss, and those by inhibiting lactation actually fall in the levels of after delivery with one of the trigger milk lactation. Now, if progesterone is the case, then let's give progesterone for those who have miscarriages, whether it is a threatened or recurrent. We have two major studies published very recently by the same authors, and in a multi-center attempts between UK and other countries in Europe by the scientist Kurmasami. The first one on recurrent miscarriage, and he called it the PROMISE study, published in 2015. And for those who had equal and more than 3 miscarriages, they give them what we call the micronized vaginal progesterone. And the outcome is stated here in the bottom: no significant difference between micronized vaginal progesterone takers and others who are not taking anything, so no placebo. And then in 2019, they published the PRISM study, where they took the group of threatened miscarriage, those who have pregnancy with bleeding in early part pregnancy, and giving the same micronized vaginal progesterone. Again, the outcome said micronized vaginal progesterone was no better than placebo. So, wow, we're talking about progesterone as the medication that is still we're showing here in this study that micronized vaginal progesterone is of no effect. So what happened? Then the same group looked into some systematic reviews, and they looked at the level of a different publication, where about 8 publications for the threatened miscarriages and 8 for the recurrent miscarriages, and it is listed here, which is some kind of a meta-analytic analysis of these studies, just to show which one is really giving them the effects. And we can see here that only dydrogesterone in these studies, okay, from these 8 studies, the one that has shown the significant change or prevention or reduction in the incidence of threatened miscarriage is the Pandian study. And the Pandian study, in fact, has used something what we call the oral dydrogesterone and not the micronized vaginal progesterone. And then in the group of recurrent miscarriages from all these 8 studies, the only study that has again the significant actually change or prevention and reduction of the recurrent miscarriages is the study of Kumar. And this guy also used oral dydrogesterone, did not use the micronized vaginal progesterone. So it seems to be we have to differentiate between these two progestins. And we can say that in the dydrogesterone, only difference compared to the micronized vaginal progesterone. And the reason is this. Now, when you take that progesterone from its own implant, you micronize it, you get the micronized vaginal progesterone or micronized oral progesterone. However, if you put some light on this, shed some light on these implants, you will develop some kind of what we call the oral dydrogesterone compound. So the dydrogesterone molecule is something similar to the micronized progesterone. However, it has a little bit of change in the shape, which give this conductivity, give it a better actually affinity to the receptors. And you can see here, its affinity to the receptors is about 70% compared to 50% of the micronized progesterone. So it's this molecule give a better actually receptor affinity and better actually fitting, and less actually affinity to other receptors of the glucocorticoid receptors or steroid receptors, etc. So this how it seems to be that one of the made the dydrogesterone a little bit more efficacious, and at the same time also we have that it has a better availability, blood levels, as well as the administration has lasted longer. And we can see from here also that the oral progesterone has other, beside its molecular difference, it has immunological also fact. There has been studied that worked with the dydrogesterone did not work with the progesterone alone, with other progestogens. And here we know that whenever the body, the mother received the embryo with the paternal antigen, the inert lymphocytes will be stimulated, and of course develop progesterone receptors. They don't develop estrogen receptors. And as a result, when the progesterone really fit on those lymphocytes, they start to make a compound called the actually progesterone-induced blocking factor. And this actually increase the level of the cytokines from T helper 2 cells, which is the anti-inflammatory cytokines, and reduce the Th1 cells activity. And as a result, pregnancy will maintain. And an experimentation on this level showed that whenever you block that progesterone approaching to the receptors that reduce the PBF, and then the Th1 instead will increase and lead to miscarriage. Or if you give an anti-PIPF medication or drug, then actually you do the same thing. You increase the Th1 cells and pro-inflammatory cytokines, leading to miscarriage. Experimentally, here, actually not just the progesterone. Here's, in fact, with the effect of changing levels of dydrogesterone in the lab on these lymphocytic cells, and showed that as you increase the dose of dydrogesterone, the PBF is increased. So we have here some evidence from the lab also to support the fact that actually dydrogesterone has a very specific effect on the lymphocytes. As a result, we had in Saudi Arabia, we formed a committee looking at the different progestins, just to find to put some kind of guidance or regulations on the to manage miscarriages. And we published our paper in 2019, and they said, which is the rule of progestogens and threatened and recurrent miscarriages. And we use this as an update for our original findings. What we have really looked at is the different multi-center study systematic reviews that has been published regarding use of dydrogesterone and use of micronized vaginal progesterone. And we can see here there is actually yes means there is an effect of these of dydrogesterone and in these studies, while it has no effect on in this there's again for threatened miscarriage. Yes, the dydrogesterone has an effect. Yes, while the micronized vaginal progesterone does not. And if we look at the actual numbers, and I just took these studies in details, there are 5 RCTs in this systematic review where they found 47% reduction in the odds of miscarriage. In Lee, 2017, 9 RCTs, and collectively found 43% reduction in odds of miscarriages, and so on. You can see it in the rest of the slide here. So what is the drug that will save the life of the embryo or the fetus? Is actually oral dydrogesterone with a success rate of 50%. So as a result, our guidelines came to state that oral progestogens, namely dydrogesterone, are well tolerated and actively reduce the miscarriages, while the micronized vaginal progesterone does not do that. Injectable progestins, actually, we had found no supporting evidence that it will work. And we have actually alluded also to there is no evidence to support the combination. If you're using oral plus injectable plus vaginal, we can see this many times in our clinics, but this is nothing to support that. We always say monotherapy is the ideal one. And also we have alluded to the safety of the drug itself. And then at the end, we made two statements regarding the management of the threatened miscarriage. One for the threatened miscarriage, where we actually have specified the dose of giving 4 tablets, which is 40 milligram at once as a loading dose, and then 2 tablets or 3 tablets a day for till the 1 week after the bleeding has stopped. Or in other words, actually for the recurrent miscarriage, we tell the patients, once you get married, pregnant again the next time, start from the day of positive pregnancy test with dydrogesterone 2 tablets a day till week 20 of gestation. And Russian actually demographic project has came out to state something similar, particularly naming the progesterone, that it has really improved and saved lives and added actually to the number of children born as a result of treating miscarriages, or even including the IVF cycles. So dydrogesterone, in fact, is a safe. It has been used for a variety of indications worldwide, and estimated about 113 million women since 1960 has used it. It was approximately 20 million fetuses being exposed. Exposed to in utero, which demonstrate its continued favorable safety and tolerability. Dydrogesterone is a progestogen that is highly selective and is not really androgenic or anabolic or has any corticoid effects, and most of the support is significant for its use and its safety. Finally, this is my take-home message. Doctors may take miscarriage lightly, as it is an early pregnancy loss, while it has a great psychological impact on the mother. There is no place for an expectant management with miscarriage. Idiopathic recurrent miscarriage should be managed with progestogen rather than any other empirical treatments. The only safe progestin with the strongest evidence so far is dydrogesterone, and I can recommend our guidelines, which is really stated down below here, to look for the dosage. And thank you very much.